Okay, so for the serum biochemistry, we can see that the sodium is at height normal, indicating there's hemo concentration, and also the height urea indicates azotemia due to the CKD. Next. And for the total protein at the height normal site, due where the albumin is with hypoalbuminemia and also hyperglycemia. The hypoalbuminemia might be due to inhibitors, and the hyperglycemia might be due to infection or inflammation. Next. In October, uh, we tried to we could not get a proper ultrasound picture or video. However, the findings were presence of cysts within the kidney and also perirenal fluid accumulation with a diagnosis of perinephric pseudocyst, which is an incidental finding. And also we can see there's presence of layers of the intestine, which indicating normal intestine. Next. From the quick PCV and PP, we can see there's the reduction of the PCV from 25% on the 12th October to 20% on 16th October, and it reduced more to 90% on the 20th October during its discharge. While the plasma protein can be seen to keep increasing from the 12th October until 20 October. Next. We also do urine SG refractometer where the result are 1.031. And we also do the staging and substaging of the CKD. For the staging, we can access from the blood creatinine where we do it on the 20 October. The result are 1 millimole, which is CKD stage 2. And also we can stage the CKD by using SDMA, but it not accessed because the tests are unavailable in UVH. For the substaging, we can do by the UPC ratio, which is done from the 27 September, and the results are negative. And for the blood pressure monitoring, we done it on the 18th October from the right column, which is the cat is normotensive. So therefore, there is no or minimal risk of target organ damage. Next. There's a problem list. For the problem hematochezia and diarrhea, we cannot be able to rule out neoplasia of the lower bowel, parasite and virus. However, we cannot rule out the uremia due to CKD, colitis, IBD, and also bacteria as it need further diagnostic workup. Next. So for the problem renal azotemia, we already diagnosed it as a CKD stage 2, and also the impotence due to the problem number 1 and number 2, where we cox and phosphate the cat. So the definitive diagnosis is a chronic kidney disease stage 2.
So for the treatment plan, for first problem, uremia, Gracie was maintained on IV fluid through a lactated renal solution, 60 ml per kg per day with diuresis rate. From day 1 to day 9 to flush out the urea. She was also given Azodil 1 tab per os SID from day 1 to day 9 as well for probiotic supplement to support the kidney health. For the second problem, which is the hematochezia, she was given methylcobalamin, 1 tab per os SID from day 3 to day 8 for production of red blood cell. Sodium ferrocitrate or ferrocite, 1 tab per os SID from day 5 to day 7 as iron supplement. She was also given double poietin at 1 microgram per kilogram every subcut every 7 days to stimulate erythropoiesis. She was also given ranitidine at 0.5 mg per kg twice a day IV from day 1 to day 8 as gastric and intestinal protectant. For the third problem, which is diarrhea, she was treated with caulipectin, 2.8 ml per os TID from day 1 to day 9 as anti-diarrhea and gastrointestinal protectant. So next is the case progression. First, for the hematochezia, as you can see from the top left, picture taken by owner on 11 of October, Gracie defecated fresh blood, but on 13 and 15 of October, Gracie defecated with score 1 feces and only 1 blood spot was observed. On 18 of October, Gracie's defecation was a mixture of fecal score 2 and 4, and there were no blood spots observed. On 19 of October, she started to defecate a well-formed feces with a fecal score of 3 and no blood spots as well. However, on 20 of October, the day of discharge, Gracie defecated with fecal score of 3 and there was 1 blood spot observed on the towel as well as in the litter box. Next is the progression of the CBC and SBC. As you can see, on 12th of October, the PCV was at low normal, which is 26%. However, post-treatment, the PCV has dropped to 19%, indicating that Gracie might be having non-regenerative normocytic normochromic anemia. For the leukogram, comparing the result obtained from 12 and 20 of October, the result on 20 of October shows leukocytosis, left shift neutrophilia, and monocytosis, suggesting active infection or inflammation. As for the serum biochemistry, the serum biochemistry, the value for urea and creatinine obtained from private clinic were high. However, at UVH, the value for creatinine shows within normal range, both on 12 and 20 of October. However, the value of urea maintained high, which indicates exothymia due to renal disease. For the total protein, albumin, and globulin, the results obtained from the private vet as well as UVH post-treatment shows hypoproteinemia due to hyperglobulinemia, suggesting infection or inflammation. So the prognosis for this case is poor because CKD is irreversible and it is a progressive disease. And if the PCV continues to drop further, we might need to consider for a blood transfusion for Gracie. So for the client education, the owner might have to monitor the feces for further hematochezia, as well as to assess the mucous membrane for signs of anemia. We can also provide a renal diet which is low phosphate and sodium with adequate protein, as well as GI diet which is rich in fiber. And also to have a revisit with a veterinarian a week after to reassess the PCV and subsequently administer double poietin injection if necessary. And owners should also provide unlimited access to fresh water at all times and monitor the water intake and urination. Owner should also consider to give canned or wet food if water intake decreases, and lastly, to follow the treatment as given and advised. That's all from us. Thank you. Is there any question?
Are there any question in the chat box?
Hi, Chang asked, sorry, I might miss out, what are the cause of hematochezia in this case? So we suspect that it could be due to the uremia due to CKD, meaning that the cat might show uremic signs, or colitis. However, colitis was not ruled out in this particular case because we did not do any further diagnostic workup for that.
So students, I want to ask,
So Chang asked,
negative. Is there such thing as
is it
UPUC
common?
negative? Can you hear me?
Again, doctor?
If you have got a UPUC that is negative, is there such thing as a result called negative for UPUC? Or is there a better term for it?
Could it be non-proteinuric, doctor?
Yeah, non-proteinuric would be a better term. But
Yeah.
often for me, the way you put your staging and your sub-staging, you are actually gathering information on different dates. So for you to stage a CKD, you might want to use like, creatinine, SDMA, UPUC, and the BP findings from a same similar date, if that's possible to stage the CKD. That's just a comment from me.
Definitely, doctor, but we couldn't get an updated urinalysis. Therefore, we just stage it as chronic kidney disease stage 2 normotensive.
Yeah, because the cat came in, the major concern was actually directed towards hematoschizia rather than the CKD, isn't it?
Doctor.
Yes, doctor.
Yeah.
So we have another question by Chang, which is it common to have hematochezia in a CKD cat due to gastric ulcer? Unfortunately, it's not common to have hematochezia due to gastric ulcer. Usually, For gastric ulcer or ulceration in the small intestine, usually the feces would be melena instead of hematochezia. Hematochezia usually originates in the large intestine. However, if the cat is in the, usually cats in stage 3 or 4, they might show uremic signs. So hematochezia could be apparent in that stage. Are there any more questions? If no, we'll proceed to the ICU case. Is that okay, doctor?
Please go ahead.
So good morning, everybody. We're from Rotation Group 1, and we'll be presenting an approach to end-stage kidney disease in a dog. Please excuse any background noise because they're still treating patients, and please feel free to stop us if you need us to repeat anything. Thank you. Sorry about that. We will just share our content again.
So this is Amoy, a straight female dog, aging of 16 years old, weighing 4.4 kilogram. She was managed indoor with access to the surrounding house compartment. For the history, 1 to 2 months ago, she started to having intermediate vomiting, but the dog still eating and drinking normally according to the owner. And the owner assumed that it is normal for the dog. And then on 24th of October, the owner noticed there's no appetite, and she was found recumbent on the next morning. And then she brought to UVS and warded in medicine due to vomiting and inappetence. And then on in the evening, she was brought to the ICU due to vomiting yellowish greenish color, and also she is appear more dull and depressed. On 7 p.m., we contact your owner and was informed that Amoy had not urinated for 3 days. And prior to coming to UVH, the dog was brought to private clinic and the blood test was done. So at this moment, the problem is anuria with differential diagnosis of acute kidney injury due to leptospirosis or nephrotoxicity. And second division will be the chronic kidney disease due to obstructive CLUTD, pyelonephritis, and also neoplasia. So the second and third problem, which is vomiting and moribund due to problem number 1. So our plan is to do a urinary catheterization and retrieve the blood result from the owner and also to monitor the urine output. So the CBC result that we retrieved from the owner shows that no significant finding on hemogram, and there's a lymphopenia and neutropenia in the lithogram. In serum biochemistry result shows uremia with sign of vomiting and no appetite, and also having elevated total protein due to hypoglobinemia due to inflammation.
So in the case of a healthy kidney, there are functional units, in other words, nephrons that function to filter the blood plasma and produce a glomerular filtrate, which then becomes our urine. So this is very important because it reabsorbs the water and sodium ions as needed, as well as removes potassium ions, hydrogen ions, and reabsorbed bicarbonate ions, in addition to removing the toxic metabolic waste. So then it produces what we know as urine, which contains toxic waste such as urea and creatinine, electrolytes such as excess sodium and potassium, and hydrogen ions. So when there is a loss in kidney function, it means that there is a reduced glomerular filtration rate. So therefore, there is reduced or no urine production. In this case, from the history we obtained from the owner, um, Amoy had not urinated for 3 days. So what happens in the case of anuria is the metabolic waste is not excreted, which can lead to uremia and eventually will lead to multiple organ failure. And secondly, there is also electrolyte imbalance. So especially in the case of hyperkalemia, which has cardiotoxic, which induces cardiotoxicity and arrhythmia because it lowers the potential, and this can also lead to death. And finally, we have acid-base imbalance, where there is elevated hydrogen ions that cannot be excreted, so the dog could go into respiratory alkalosis as in it will hyperventilate to remove as much as carbon dioxide as possible to compensate for this issue.
So in cases where we are presented with an aneuric patient, firstly we need to establish an IV fluid administration. This is to ensure that the patient is normovolumic, which ensures that the renal perfusion is adequate. If the patient is dehydrated, it will cause the reduce in renal perfusion, which leads to reduce in glomerular filtration rate and also reduce in urine production. But we need to also take note that if the patient is actually aneuric, and we need to avoid any overhydration, since this can lead to a volume overload, which will lead to hypertension and edema. So after we have assessed the dehydration status and make sure that the animal is normal volumic, we need to establish a urinary catalyzation. This is to allow us to monitor the urine output accurately, thus able to assess the treatment effectiveness. This also allows us to classify the patient whether it is polyuric, oligouric, or aneuric. Next, after establishing the urinary catalyzation, we can give a dosage of furosemide as a diuretics. This is to reduce the sodium retention, which increase the tubular flow rate and also increase the urine output. This increase in urine output has increased the rate of which the toxin is removed from the body. So after giving the furosemide, we can also give low dose dopamine, which acts as a renal vasodilation, which increase the renal perfusion, which in turn increase the urine output. This low dose dopamine is essential to ensure that the adequate renal perfusion allows sufficient concentration of the furosemide to reach the kidney, which allows the furosemide to act accordingly.
So these were the procedures that were performed on Amoy, and we will be talking about the urinary catheterization in more detail. So the procedure begins, and what is required is basically all the all the materials required as listed as below, as well as a Foley catheter. So first, the patient is placed in ventral recumbency with the hind legs at the edge of the examination table, and then we clip the perivalvular area and clean and aseptically prepare the area. Then the vestibule was infused with 1 to 2 ml of 2% lidocaine. Lubricated finger of the dominant hand was then inserted between the labia of the vulva, directed dorsally, then cranially at an angle to enter the vestibule until a muscular thickening, the junction between the vestibule and vagina, is palpated, and the finger can no longer be advanced. So from here, we can then insert the catheter, because we prevent the catheter from entering the vagina, inserting the finger this way. So when we locate the urethral opening, just caudal to the junction, as shown in the diagram here, we can then advance the catheter into the vestibule. So the hand with the finger inside the vagina can then gently guide the catheter to the urethral opening. And once the catheter has entered the urethra, placement is verified by palpating the papilla over the catheter. So when it's verified, we can then further advance the catheter into the bladder, and then finally remove the stylet and secure the catheter by inflating the balloon in the catheter with the saline, so it will not slip out. So in this case, no other fixation is necessary. Finally, the catheter is then attached to a urine collection bag and the urine output was monitored.
So after the catheter was established, furosemide 1 mg per kg is administered intravenously along with dopamine 0.5 microgram per kilogram per min (CRI). And then the patient is monitored for 30 minutes. And if there is any urine output observed, it will continue to be monitored for over 6 hours for volume responsiveness or any oliguria or anuria. However, if there is no urine output observed, a second and a third dose of furosemide 1 mg per kg IV can be administered and monitored after every 1 hour interval. So volume responsiveness is defined as an increase in the urine production to more than 1 ml per kilogram per hour in 6 hours of monitoring, with or without the decrease in serum creatinine to a baseline over 48 hours. So a normal urine output in adult is usually 1 to 3 ml per kilogram per hour, and oliguria is defined as less than 1 ml per kilogram per hour, and anuria is less than 0.25 milligram per kilogram per hour.
So the diagnosis for this case was end-stage kidney disease. However, we were unable to determine the exact kidney disease due to the dog being euthanized at 8 p.m. due to after discussion with the owner of the poor prognosis. Are there any questions? Doctor, sorry, if there are no questions, can we end the round? Hi everybody. So if there are no further questions on the case, we will end the round. Thank you so much for